Welcome back to Scott Asmar, the man and everything in between. And as you can see, I am not in my studio. I am in gorgeous Hawaii, and I am with my brother-in-law, Dr. John Abdulian, and we are attending a conference on gastroenterology. But before we get started, I'd like to formally introduce my brother-in-law, Dr. John Abdulian, and he is a gastroenterologist. And Dr. Abdulian, can you give me a little background on your education and your practice?
Okay, well, I was born and raised in Los Angeles, and my college degree was from UCLA. I also have a master's degree from UCLA, and then went to medical school at St. Louis University, where I got my MD degree. I did my fellowship in gastroenterology at Loma Linda University and have been in private practice since 1994 in 3 different locations, initially Los Angeles, then Dallas, Texas, and now most recently in Fresno.
And how long were you in Dallas?
10 years in Dallas, 11 years in Los Angeles, 10 years in Dallas, and now it's going on to my 11th year in Fresno.
Wow. And so that sparks a question for me. Is the people in Dallas, as opposed to the ones in California or the people in Texas, did you see any types of difference, or is it kind of the same things you see across the board?
In the disease states, it's pretty similar, because I think the Texas population is pretty similar to that of California. Obesity is endemic. So you have a lot of obesity-associated type diseases like fatty liver, etc. I don't think there's huge differences in some of the more common disease states like colorectal cancer, gastroesophageal reflux, and complications of these problems. Inflammatory bowel disease, pretty standard throughout.
And what are some of the common things you see in men over 50? Like what pops up regularly?
In men over 50, probably the most common thing we see is gastroesophageal reflux.
That's what I suffer from.
Yeah, because it's very, very common, because you need to have some ability to belch, basically, because you have air accumulation in your stomach and you have to vent it. So the lower esophageal sphincter muscle has to relax in normal health to allow things to come up for venting purposes. And if you have a bunch of gastric contents, including acid coming back up, that is by definition the gastroesophageal reflux, and it's related to either a weak lower esophageal sphincter muscle or a muscle that relaxes too frequently.
So when you did my endoscopies, because you do all my endoscopies and colonoscopies, so what did I have? Did I have that like it was two?
It wasn't bad. I was expecting worse.
but it wasn't too bad.
No, it wasn't. I mean, most people that have gastroesophageal reflux have very small hiatal hernias. A hiatal hernia is a little bit of a pooching of the upper part of the stomach, the fundus above the diaphragm.
Okay.
The diaphragm serves as a natural barrier, pressure barrier to gastric contents from coming back up into the esophagus. And not uncommonly, people that have reflux or suffer from reflux have hiatal hernias of variable size. But everybody with a hiatal hernia doesn't necessarily have to have reflux, but it's a very common finding.
So mine was kind of...
Yours was a small hernia.
Oh, that's good. That was positive. So we're here at this conference, and you've been coming to the Guild now for how many years?
Well, it started 10 years ago. I didn't attend the initial one, but over the 10-year period, I've attended 5 of them.
5, okay. And the Guild stands for Gastroenterology Update, IBS, and liver disease. Is that right? Is that what Guild stands?
Inflammatory bowel disease.
Inflammatory.
It tends to focus on inflammatory bowel disease, ulcerative colitis, and Crohn's disease. And then the first 3 days of the conference, or 2 days of the conference, are exclusively inflammatory bowel disease and related entities. and the last day is the liver day.
As a liver day, okay. So when we were there at the conference, two things caught my attention. Was the psychological or psychology link to gut health. So what was your take on that? Because what I gathered from there was like they were wanting the gastroenterologist to do a preliminary assessment of the psychological well-being of the patient.
Yeah. Well, one of the really underappreciated things is how much depression and other psychiatric illnesses are present in people with inflammatory bowel disease, which is a huge stressor, of course. And it's not really addressed by most gastroenterologists. And I think some of the university programs now are starting to focus on that aspect because the mental health has a profound impact on symptomatology. The GI tract actually has more neurons in it than any other organ in the body.
Oh, wow.
So it's really susceptible to mood and especially to stress. Everybody has a different reaction to stress. Some people, when they're stressed, get anxious and jittery. Some people get headaches. And one of the common things that we know of course, is that a lot of people get diarrhea when they're stressed out, like diarrhea right before a big test. That's not an uncommon scenario. So there is always going to be a huge overlay of psychiatric and other nerve or brain related issues that describe the brain gut axis.
Yeah, brain gut. Brain gut axis.
And some of the interesting things, when people come into the office with complaints of abdominal pain, bloating, diarrhea, oftentimes it's not from structural abnormality. It's what we call functional bowel disease. Functional bowel disease is the way that it's basically a hypersensitivity more than anything else, but it's the way people interpret the different things that stimulate the GI tract. When you consume some food, your stomach has to stretch to accommodate it, has to empty at a certain rate. And if you have disorders in either the accommodation of the stomach or the emptying of the stomach, you can have significant bloating.
Yeah, that's what I suffer.
And it's not, and it's not related in most cases to an ulcer or anything that's actually causing a mechanical obstruction. It's related to failure of these other functions, which are not visible to the naked eye, basically. When you do an endoscopy, the GI tract looks normal.
So between like women and men that come into your practice, is the bloatingness one of the main symptoms that they're having?
Good question. I think men have more of the bloating issue, and I think women have more of the colonic things with irritable bowel syndrome. Irritable bowel syndrome, as opposed to inflammatory bowel disease, where you have actually inflammation. Irritable bowel is bowel hypersensitivity, and there's clearly differences in gender in terms of the amount of these diseases or these processes.
So what I'm hearing you say is the men come in with more bloating issues, women come in with more irritable bowel.
Yeah, I think a lot of it is because of the characteristics in which people eat. Sometimes men tend to overeat, I think, more than women, eat more rapidly, and it's more difficult to digest. And women, I think, have more bowel hypersensitivity for whatever reason. In fact, some medications that were developed for irritable bowel disease were developed only for women, because women were the vast majority of people suffering from that condition.
Interesting. And the other topic that focused on is the AI and gastroenterology. And I thought that was fascinating as well, that one of the main concerns with the speaker communicating to the group was that AI is not going to take over the endoscopy. What's your feelings about AI and gastroenterology?
I think AI is going to have its place, definitely. And the hope is that it will aid in some of the tasks that that take up physician time that could be utilized in more fruitful ways. AI is good at identifying patterns and patterns of disease.
Oh, yeah.
And it's hopefully will be utilized in that aspect. AI will be used for detections and try to improve things. But the problem with AI is it's a language based, and they brought up one a specific AI recommendation, as Scott remembers, and that was, how do you make your cheese stick better on your pizza? And it's by using Elmer's glue. The guy was being facetious, but AI, that was the answer. The AI picked up on that, and they couldn't differentiate because they don't know what's valid, what's invalid. It's just kind of a summation. So there are errors that are going to be made by AI. You need to always have the human oversight. AI sometimes has a difficult time in discerning things. You always need to have the physician, and AI doesn't have the motor ability to do things.
So they can't take what you do. They can't take that scope down. AI is not
at this time.
Yeah.
You never know. 100 years from now, you never know.
Well, yeah.
It might be, like Star Trek, days where you don't need to do colonoscopies. You can scan somebody and eliminate things. You never know what the future's going to hold.
And you also mentioned to me there was a capsule you take.
There's something called capsule endoscopy, a wireless capsule endoscopy.
Wireless, yeah.
What that is, it's specific for detection of disease in the small intestine. At least that's the utilization in this country. You can swallow a capsule that's got a camera in it, and then as it goes through the GI tract, it records images, and you download those. The patient that has swallowed this capsule wears a recording device. The capsule transmits the images to the recording device. And we download it on a computer, and we can look at the different images. And that's for trying to detect disease in the small intestine, which is not really readily accessible with endoscopies.
I see.
So that's what
happens to that capsule. It just comes out.
It just comes out. There are very, very rare cases where the capsule gets stuck. You need to make sure that you don't use it in somebody that you suspect has an obstruction somewhere, because it will get stuck.
We talk a lot about the endoscopy, and I know a lot of people don't like to talk about the colonoscopy, but colonoscopies are very important. In fact, do you rank those about even more important than the endoscopy?
Oh, much more important. Let me first give you some background. Colorectal cancer in the United States is the third most common cancer and the second leading cause of cancer death in the country.
Wow.
And it's a shame because it's very, very preventable. Certain populations are very at risk for colon cancer. African Americans, right there at the top. There has been so much detection of cancer at earlier ages now that actually the screening recommendations have dropped to age 45.
Oh, wow.
All comers. And of course, we have a family history. We start earlier at age 40 or 10 years before the family member developed colon cancer, whichever is earlier. So it's very, very, very common and so preventable.
So what would you recommend to men of 45 and older?
Get your colonoscopy, number one. And number two, decrease your colon cancer risk factors, which are going to be obesity, alcohol, tobacco, and the Western diet, a high-fat diet. If you compare black men in the United States versus black men. In Africa, the rate of colon cancer is much higher in the U.S. because of the diet. In Africa, they tend to consume diets that are rich in fruits and grains, etc., not as much meat, versus the processed foods, high-fat diets that are typically consumed in the United States. So alter your diet, lose weight, don't smoke or drink. That's the best way to reduce your chance of getting cancer.
So is it still every 10 years, a person who has no history and just goes for screening? Do you recommend every 10 years? Because my thought is, what happens if you go with the screening and then like 18 months later, you would start having symptoms or something? I mean, like, should you go every 5 years?
No, well, 10 years is based on, the statistics, the studies, and what the time it's thought to develop from a normal colon to a cancer. So 10 years is set there. It's shorter if there's a family history.
Family history, okay.
It's, of course, shorter if you find polyps and remove polyps from the colonoscopy. That's a big advantage to colonoscopy over other modalities used for screening colon and rectal cancer. With a colonoscopy, not only is it diagnostic, but it can be therapeutic. Polyps are cancer precursors, and they can be identified and removed, and cancer can be prevented. It's intuitive, and it has actually been shown to be true.
So the bottom line is, for all population, but especially, with men, get screened.
Women have cancer too. Men have about a 30% higher incidence of
30% higher rate.
Yeah.
Wow.
So men especially, but both genders, and both genders start at age 40. For family history, 45, no history.
I see. So out of the 4 days of the conference, what will you take back to your practice with this information? Because I thought it was full of information, and of course I'm not a medical doctor. What will you take back to the practice?
Well, I think a couple things. One, I think is the AI is not going to replace us, and what the pitfalls of AI are. I think that another thing I took back that we haven't really talked about is the foods and the different types of processed foods and the problems that they create. And now I'm committed myself personally to stay away from some of these processed foods. I'm not going to.
That's what I was going to ask you. What should a human being stay away from altogether?
Yeah. I think, they did say, though, absolutes are usually not required. You just need to do things in moderation.
Yeah,
so
I did hear that.
This with a little bit of a grain of salt, but in general, certainly processed foods are not good for people. Food additives and dyes and preservatives are definitely problematic.
So that's what Kennedy's doing, is trying to get that stuff out of.
Yeah, from the school lunches and things like that, which I think is a good idea. Whether it's practical or not, is the problem is that those food additives and preservatives are used so that those foods can have a longer shelf life.
Right.
And then when you send something to a whole school system, you can't get fresh fruits and vegetables and meats to a whole community.
Right.
That's something you can do at home, but for schools, I think you're stuck having to rely on things that have a longer shelf life.
And what about foods that are a necessity to have? Like, what should somebody incorporate in their diet?
Well, there's certain amino acids like tryptophan that are not naturally made. So you have to. There's some amino acids that you need to.
What foods have tryptophan?
Well, you know what? That's a good question. I don't know off the top of my head. I think what I would do is Google, for those interested, essential amino acids. Essential amino acids are going to be things that you have to get exclusively through diet.
Okay.
And then you can extrapolate what specific foods contain these, and that would be the best and safest way to go about it.
Okay, very good. You're located in Fresno, so do you have your website or?
You know what? You can look. The group that I am a provider with is called Fresno Digestive Health, and we have a website. If you go and Google Fresno Digestive Health, you will see a list of our providers. All of them are very, very well trained and competent, and we can certainly accommodate almost everybody that inquires.
Well, Dr. John, thank you so much for inviting me to
pleasure.
this conference. I learned a lot, and I'm so happy that you're a guest on my podcast. And
thank you for having me. It was enjoyable.
Well, we'll have to do a follow-up too next year.
Anytime. When we come back next year, we'll do the same.
Yes. Well, thank you again.
My pleasure, Scott.